To begin, we'll go over a little bit of introductory information about vancomycin. Vancomycin is a glycopeptide type antibiotic that only has gram-positive activity. It does not have any coverage of gram-negative organisms. Its spectrum of activity includes Staphylococcus species, including methicillin-resistant strains, Enterococcus species, particularly Enterococcus faecalis, and Streptococcus species. Vancomycin works by inhibiting synthesis of the bacterial cell wall and is bactericidal for most organisms except Enterococcus, for which it is bacteriostatic. Remember that a bactericidal antibiotic kills the organism, whereas a bacteriostatic antibiotic simply impedes further growth. It's important to remember also that different types of antibiotics have different pharmacodynamic profiles. Vancomycin's is defined by the ratio of the 24-hour AUC to the MIC of the organism. The most optimal bacterial killing occurs when this ratio exceeds 400. Now let's review what the terms on this picture mean. AUC is the area under the curve. For vancomycin, we will want to know what the 24-hour AUC is. The MIC, or minimum inhibitory concentration, is the minimum concentration of an antibiotic that will inhibit visible growth of the organism over an overnight incubation period. Cmax is the maximum concentration of the antibiotic after administration of a dose. Like I said before, different antibiotics have different pharmacodynamic profiles. Some are time-dependent, meaning that they have optimal antibacterial activity when the concentration of the drug is above the MIC for a longer period of time. In this case, it doesn't really matter how high above the MIC the concentration gets. Others, like the aminoglycosides that we'll talk about next week, are concentration dependent. These work best when the concentration to MIC ratio is higher, so it's important to reach targeted Cmax or maximum concentration values with these drugs. Finally, vancomycin has the best antibacterial activity when the AUC 24 to MIC ratio exceeds 400. Vancomycin is not systemically absorbed when given orally, so only the intravenous form may be used for systemic infections. This drug has a wide distribution into body tissues and can even enter the cerebrospinal fluid fairly well in the setting of meningitis when the meninges are inflamed. Vancomycin has a volume of distribution that varies widely from 0.4 to 1 liter per kilogram. Vancomycin doesn't undergo much metabolism. It's primarily excreted via the kidneys as unchanged drug. Because of its dependency on the kidneys for elimination, its half-life varies widely depending on the individual patient's renal function. Like I said previously, vancomycin isn't absorbed after oral administration. The only time that you should consider recommending the use of oral vancomycin is for its local effect in the treatment of Clostridium difficile colitis. What we'll be focusing on today in this lecture is the intravenous use of vancomycin for systemic infections. The dosing of IV vancomycin is very patient-specific and can vary widely. For example, from only 500 milligrams every 48 hours for a small person with poor renal function, all the way up to 2,000 milligrams every 8 hours for a perhaps younger, larger patient with very good renal function. Typically, vancomycin is infused over several hours, with the maximum rate of administration not to exceed 1 gram per hour. Vancomycin is used in a number of different clinical scenarios for either empiric or targeted treatment of serious gram-positive infections. For empiric treatment, it's usually selected as the antimicrobial of choice if infection with MRSA is of concern. Some types of infections that vancomycin might be used for include those listed on the slide above, but recognize that this list isn't necessarily all-inclusive. There are several important adverse effects of vancomycin that you should be aware of. First are those that don't necessarily depend on the concentration of vancomycin in the patient's blood, but are more so related to the rate of infusion of the drug. Red man syndrome is characterized by pruritus, itching, and erythema over the face, neck, and trunk. This is usually caused by a too rapid infusion of vancomycin. Tachycardia, hypotension, and phlebitis, or irritation and pain at the site of the infusion, may also occur with a rapid infusion. These can be minimized by being sure that vancomycin isn't infused faster than 1 gram per hour. So for example, if the patient is to receive a 2-gram dose, this should be infused over a minimum of 2 hours. Nephrotoxicity and ototoxicity may also occur secondary to treatment with vancomycin, typically when vancomycin levels in the blood are elevated. Nephrotoxicity may be reversed with cessation of treatment in many scenarios. However, ototoxicity may be permanent. Both nephrotoxicity and ototoxicity may be more likely to occur if vancomycin is given in combination with other drugs that may cause these effects.